Give it another minute or so as people.
Recording in progress.
Welcome to our very cold morning, first ACC of 2024. I'm delighted to introduce our first speaker of the year, Jocelyn James, who is an assistant professor of medicine at the University of Washington. And she is both an internist as well as an addiction medicine provider at Harborview Medical Center. And she also is the director of the satellite clinic, adult medicine clinic embedded within Evergreen Treatment Services, which is, as we probably are familiar with in the Seattle area, an opioid treatment program. She also attends on the inpatient addiction consult service and does a number of other things, including teaching as well as research in hepatitis C and care of people with substance use disorder. She's given a number of talks for ACC, so some of you already may be familiar with her. And today she's going to be talking about updates on methamphetamine use and treatment. So thank you so much, Jocelyn.
Yeah, thank you so much, Shirisha, and thank you for having me. As Shirisha said, today I'll be talking about methamphetamine use and treatment. And my slide is not advancing, so let me see what happened there because it was a minute ago. Okay, try a different route. So I have no conflicts of interest to disclose, but I will be discussing off-label use of medications for methamphetamine use disorder. There are no FDA-approved medications for methamphetamine use disorder. So why talk about meth today? Well, it really is everywhere, especially here in the United States. And while there is an appropriate focus on the opioid overdose epidemic, meth is really a big part of that story. This is from a New York Times article in 2018. And as the writers said, the drug has never been purer, cheaper, or more lethal. I have a fairly long agenda today, but please don't worry. Most of these are very short sections, and I will try to leave some time at the end for questions. And at the end of this, what I'm really hoping people take away is a refresher on how are the ways that methamphetamine use may be affecting my patients and what might be offered to them to help them with their use or to help keep them more safe. I want to start with a question, and I have a couple of these questions in the talk. They're not truly audience response. We don't have that set up for today, but it's really just to give us a chance to think back to what we may have learned in the more or less remote past about methamphetamine use. So to start with, which of the following statements about methamphetamine is not true? It's extremely reinforcing due to indirect agonism at noradrenaline, serotonin, and dopaminergic receptors. Withdrawal from methamphetamine typically lasts days to weeks. Cravings for methamphetamine can last months, contributing to recurrent use, or respiratory failure is the most common mechanism of death related to methamphetamine use. And I'll come back to these in the coming slides. So to start out with, though, what is meth? How do people use it? It is indeed a very potent and addictive psychostimulant, and it's an indirect agonist on major monoamine channels and monoamine transporters in the brain, so it has indirect agonism at both serotonin, noradrenaline, and dopaminergic pathways, and it's really the dopamine pathway that's probably the most important. Dopamine is flooded into the synaptic cleft in the setting of methamphetamine use, both because it blocks the reuptake of dopamine, but also because through multiple mechanisms, the release of dopamine into the synaptic cleft is increased. Interestingly, opioidergic pathways are also affected, and this comes into play, as we'll see later, there's some overlap in the cravings and reinforcement between opioid use and methamphetamine use. But in addition to being a very potent stimulant, methamphetamine is also a highly toxic drug. It causes oxidative stress, neurotoxic effects, and neural inflammation. So it's really an extremely harmful substance. It comes in many forms. Powder, often referred to as meth or speed. Crystalline forms, often referred to as crystal meth or ice. It also comes in pills or liquid. And it can be used in a variety of ways, most commonly smoked or used intranasally or injected. but it can also be used rectally or orally. And there's really not one stereotyped pattern of use for methamphetamine. There are multiple or variable patterns of use. Some people will use every day. It's fairly common to use every few days. And then some people will use really more on an intermittent or binging basis. All right, so I'll turn now to some of the effects of methamphetamine use, both acute and chronic. But start with this figure from SAMHSA. And I like this because it shows the increasing psychoactivation that occurs with methamphetamine use as you increase the dose or potency. So when someone starts using smaller doses of methamphetamine and then increases those, there's increased cognitive activation and cognitive enhancement, vigilance, wakefulness, increased attention. And of course, those are often desirable effects. But then as the dose or the potency increase, people can get a sense of power and euphoria, and those are often what become involved in development and ongoing use disorder, a methamphetamine use disorder. And when people experience those effects, they're more likely to also be at risk for some of the cognitive deficits that can occur. And then as the dose or the potency is increased further, people are at much higher risk for overdose, psychosis, coma, and eventually for circulatory collapse. But another way to look at it, as I mentioned, is to think about the more acute effects of methamphetamine use and then the more chronic effects, or rather effects of chronic use, really. So here, looking at acute effects, you can see there are many, and this is not at all exhaustive. But in general, on the left are some effects that might be considered more desirable, and on the right, some less desirable or even adverse effects of methamphetamine use. And often, as you can see, it's kind of two sides of the same coin. So there are potential benefits to mood, feeling good, positive mood, euphoria, a more kind of social behavior, talking more. And then on the other side of that, it's very common for people to experience anxiety, depression, hostility, and in some cases, really bizarre behavior and even psychosis. Similarly, on the left, you'll see, people may have less need to sleep, less need to eat. But on the other hand, there can be really in a different person or a different circumstance, or maybe with a different pattern of use, we also will see trouble sleeping and unintentional, negative, harmful weight loss. And then, of course, people are also at risk for some of the cardiac events and for neurologic events such as seizures. So when it comes to methamphetamine use, unlike opioid use and opioid overdose, there's really not a clear correlate to that. There's not a stereotyped presentation of overdose, but this term overamping is sometimes used to refer to the negative or uncomfortable experience from using methamphetamine. And of course, in some cases, that can become life-threatening. So what about with chronic use? As with many other substances, with these chronic changes in the brain, we get downregulation of receptors and transporters and depleted monoamine stores. So with just the abnormally high levels of those monoamines that I mentioned, the receptors are downregulated, the stores are depleted. And so that can lead to withdrawal symptoms and to cognitive loss and psychiatric and psychomotor symptoms. And some of the psychomotor symptoms you may have seen include the compulsive repetitive behaviors, or almost like a Parkinsonian presentation. But I mentioned earlier that meth is also very neurotoxic, and through those toxic effects, we'll see just direct damage to the brain, in addition to the heart and other important organs. I wanted to highlight methamphetamine-induced psychosis because it's one of the most distressing effects of methamphetamine that I've seen. It appears, for patients, for their families. I believe can be very distressing and difficult for healthcare providers. So methamphetamine-induced psychosis is also pretty variable in presentation. It often lasts for hours to days, but it occasionally lasts for 6 months or more. It's increased it's more likely to occur with high doses of methamphetamine, high potency meth, or frequent use of methamphetamine. And it can look a lot like other primary psychotic disorders with positive symptoms and negative symptoms. So some pretty typical, almost schizophrenia-like symptoms. And the negative symptoms can include suicidality, a lot of somatic concerns, which sometimes leads people to present, and also self-neglect, which can be quite pronounced. And sometimes people with methamphetamine use disorder will present with really advanced, complicated medical conditions that have gone neglected. So how does methamphetamine, though, cause death? Really, it can cause death in any number of ways, but the primary two buckets are cardiac and the heart and the brain. And you can see that these common syndromes that can occur, all of which can be very much life-threatening. So again, there's not really an overdose, stereotyped overdose for methamphetamine, but there are a number of potentially fatal conditions that people are at risk for if they're using methamphetamine. Similarly, when it comes to withdrawal, there's no stereotyped or really obvious presentation of withdrawal. It's quite variable in presentation, but here are some common symptoms. So people may experience dysphoria and depression, trouble with sleep, and trouble with just basic functioning. You may see irritability and agitation, pain, discomfort, distress. And these symptoms can last days to weeks, but cravings, another withdrawal symptom or associated withdrawal, can last actually for months. And all of this can drive ongoing or recurrent use of methamphetamine, can make it hard for people, even when highly motivated to do so, to really put it behind them. So on that note, why do people use methamphetamine? And I don't mean at all to claim that I have all the answers to this, but there are some studies looking at this, and of course we hear from our patients why they're using, and so I wanted to highlight some reasons that I think are important to be aware of. Of course, methamphetamine as a stimulant that causes euphoria can make you feel good. It can enhance the sexual experience. It can increase concentration, but it can also be used, and often is used, to manage symptoms. So to manage pain, to treat pre-existing ADHD symptoms, in some cases to manage withdrawal symptoms, and not necessarily from methamphetamine. That is often the case, but also methamphetamine, as you'll see later, can help people even manage the withdrawal symptoms from opioids and other drugs. And then it can be used to offset effects of other drugs. So there are many reasons people might use methamphetamine. And I do want to highlight that for people who are living unsheltered, methamphetamine use has been reported to help with, to connect to different elements of what they might have to struggle with. So as this woman who was interviewed by the New York Times several years ago said, having nowhere to sleep, nothing to eat, that's where meth comes into play. Those things aren't a problem if you're using. And similarly, I've heard from a number of patients, and I'm imagining some of you have, that if they're unsheltered, they're fearful of their safety, they may be using meth really to help stay awake, be more vigilant, try to protect their own safety and their belongings. All right, I have another question to help me and you switch gears and now turn to this topic of opioids and stimulants, co-use of both. So here's another question to think about for a moment. All of the following are reasons for co-use of opioids and stimulants except. So to enhance the high from opioids, especially among those with opioid dependence, to mitigate opioid withdrawal symptoms, decrease the harm associated with opioid use, because there are overlapping drug distribution networks, for pain relief, and all of the above, all are reasons for co-use of methamphetamine and opioids. And here I'll just say that the answer here is the last one. These are all reasons given that people use both substances together. And methamphetamine co-use with opioids is considered to be the fourth wave of the opioid epidemic. So you've heard of the opioid overdose epidemic coming in waves with prescription opioids, heroin, fentanyl, and now methamphetamine and opioids. And we've known for a while that methamphetamine use is rising among people who use opioids. This is a study from 2018, and you can see in that figure on the left that they tracked co-use of opioids, past month use of methamphetamine among people using opioids. And specifically, these were people with opioid use disorder who were seeking treatment for their OUD. And so how many of those used methamphetamine in the last month? And that line, of course, increases quite a bit from 2011 to 2017. The authors found that the majority of people were using both drugs on the same day, and then they identified specific subgroups where the increases were much more prominent. The West Coast, perhaps because of overlap in, at the time, in drug distribution networks with black tar heroin, young age, so 35 to 44, and then women. In this study, they found that 39% of the women who were sampled endorsed past month use of methamphetamine. So really high numbers. It's not just that people are using them together, the combination is really deadly. And you can see that while all overdose deaths involving methamphetamine and other psychostimulants has increased dramatically in the United States, as you see here, it's now the majority of those deaths that also involve opioids. And this remains true. Why is that? Why is the combination so deadly? I don't think there's any one answer, and it clearly gets complicated, but there have been some interesting studies. There's a study from one of our local colleagues here who found that indeed there was a much increased risk. So among people in the Seattle area, or I think in King County, who were injecting drugs, people who injected heroin plus methamphetamine, this goofball, so-called goofball combination, had a 1.7 time the rate of overdose compared to people who are injecting with any other pattern. So clearly that risk is very high. Why is that? Not entirely clear. There's some mouse model data that is interesting, looking at the combination of methamphetamine and fentanyl, and found that the effects of the methamphetamine did affect respiratory drive, respiratory depression, but the effect depended on the dose. I think the probably easiest way to think about it, at least for me, is that using a depressant, a potent depressant and a potent stimulant drug at the same time places this really immense pressure and stress on the most important systems in our body, cardiovascular, respiratory, and the brain. And then it's also important that use of methamphetamine affects people who have opioid use disorder or who use opioids in other ways. So this pertains specifically to people who not only use opioids, but have a use disorder, and found that those who also use methamphetamine were less likely to receive treatment with methadone or buprenorphine, and we know those are life-saving drugs for people with OUD. They were less likely to be retained in treatment, and they were less likely to be abstinent from opioids if they were in treatment with methadone. So why use both drugs together? There have been some hints at this before, but there are some synergistic effects of the drugs, and then there are some antagonistic effects. And so people use both for that synergism. It can enhance the high, especially in people who use opioids chronically, but can also offset some of the negative effects. So like the effect of sedation can be offset by meth. Their studies have shown that some people believe it helps to reduce their risk of overdose, even though we know that that combination puts people at high risk of overdose. It's common for people to report that using them together can be helpful for pain. There are these overlapping drug distribution networks. We know there is just a lot of polysubstance use, period, right now. And you can see that, as I referred to earlier, people can also use methamphetamine if they're trying to detox or mitigate withdrawal effects from opioids. So people provide a lot of different reasons to use both together. All right, I'll turn now to some trends in methamphetamine use and overdose in the United States. So I showed on that early slide from the New York Times that there really has been this explosion of meth. And what we're seeing is that the methamphetamine is no longer being produced in the United States, but it's being brought in generally from Mexico. And so you see on the left there that the seizures of methamphetamine have really just skyrocketed. But importantly, the purity and potency are also incredibly high, higher than they've ever been. The purity has actually been high for a long time, but the potency has increased. And we are in the United States really the capital of methamphetamine use, unfortunately, and it appears that methamphetamine use in this country is increasing. But more importantly, methamphetamine The impacts of methamphetamine are increasing, and I'm not going into all the other facts here, but overdose deaths are increasing very dramatically. So between 2008 and 2019, overdose deaths related to methamphetamine and other psychostimulants increased more than 12-fold. And remember that, as I showed earlier, we now see that the majority of those deaths are associated with opioids as well. We see that these increases in overdose are out of proportion to the increases in use of meth, which has led to this question of, is it a riskier drug now? Or are there other factors in the way people are using it that make it riskier? So we do see increases in intentional use with other substances like fentanyl, heroin, and cocaine. We know that there are increases in the amount of fentanyl, or the proportion of fentanyl that's, of methamphetamine rather, that's laced with fentanyl. In fact, I know here in this area, we just assume that any illicit substance has fentanyl in it. And then changes in patterns of use, more frequent methamphetamine use. But there's also a question of, is methamphetamine just a riskier drug? There are changed processes for making methamphetamine, and also differences in the isomer that's predominant, and one more than the other has higher CNS activity and is also more potent. So there may also be things just about the drug itself. To speak to that a little bit on the changing ingredients, so people probably recall that in the past, ephedrine was used. There were these meth labs, often here in the United States. But the regulatory actions by the United States and also by Mexico really limited the supply for that. And now the method that's predominantly used is called the P2P method. And it uses a variety of chemicals, which are legal and cheap and are really important in a wide variety of industries. So much it's not possible or practical to regulate them. And production has shifted to these large, very efficient labs in Mexico, and then it's being brought into the United States. Who is at highest risk for methamphetamine use and for developing methamphetamine use disorder? Not surprisingly, this is the same overlapping, groups of people who are at highest risk of many other syndemics. So low SES, loss of housing, insurance, criminal justice involvement, people with other chronic viral infections, including HIV, people with mental health who are using multiple substances. And I want to just highlight that the risk of overdose death is particularly striking among the American Indian Alaska Native population. And you can see that's the orange line here, and that's true for both men and women. And this is also very true locally. What about methamphetamine use and HIV? I mentioned this goofball earlier, so injecting heroin plus methamphetamine. And Dr. Glick and others looked at people who inject drugs in King County, and this was up to 2017. So before fentanyl had really exploded in King County. But the idea was, we know that methamphetamine use increases the risk of HIV acquisition, transmission, non-suppression. So how do these changes in methamphetamine use affect HIV risk? And what she found was that there was rising injection methamphetamine use, and it was mostly in combination with heroin. It was mostly driven by people who are not men who have sex with men, and there was significant needle sharing between non-MSM and MSM populations. And so one of the conclusions from their paper was that non-MSM who are using meth are an emerging population who are at high risk of HIV. Okay, I'm going to shift gears again and start with another question. So we're going to think a little bit now about treatment considerations for methamphetamine use disorder. So each of the following has shown promise to treat MUD, except, and you see that list, or has all of the above been shown promise to treat methamphetamine use disorder? And I'll just say here that actually what I would consider the correct answer for this is aripiprazole. There have been studies of that medication, and it looks like evidence of harm rather than evidence of benefit. There's some evidence for these other medications, and so I will go through the others. Before I do that, I want to just introduce the idea of treating, when do we treat, and when do we treat with medications. So first of all, big picture, I think I've shown, you're probably aware from your own practice, that there are increases in methamphetamine use, in the degree of risky use, and certainly in overdose, high rates of co-occurring use with other substances. diversifying populations, it's a slide I had to cut, but essentially the populations of people who are using methamphetamine are really diversifying. So it applies to many groups of people demographically. And so we have an urgent need to expand and improve our treatment options, increase access to harm reduction, make sure people who have co-occurring disorders get treatment for those, and then really do our best to target diverse populations for prevention and treatment. Making the diagnosis, so before offering, certainly before offering pharmacologic options for people with methamphetamine use disorder, you need to make sure that that diagnosis is present. And for this, I won't spend time here. You're probably familiar, but this is essentially the DSM-5 criteria for any substance use disorder. And some of the just kind of general categories that you're looking for are loss of control or impaired control over the substance, social impairment, use in risky situations, and then the pharmacological properties of tolerance and withdrawal. And in general, people who qualify as having a moderate to severe use disorder might qualify for medication similar to the case of opioid use disorder. I also just want to acknowledge, though, that most of the studies that have been done have looked at this abstinence endpoint, which has a really high bar for studying medications, and is not the only important endpoint to people. So abstinence, of course, is this really dichotomous view of recovery. It doesn't value the other alternative endpoints that might be very important to people. And it's disincentivized medication development because it is such a high bar. And people have other things that they care about. Their symptoms like withdrawal, sleep problems, mood, reducing use, maybe not quitting, but reducing use, and staying in treatment are some of them. We know that people who use methamphetamine really want treatment. And this was a survey of people who are using methamphetamine and are not seeking treatment. And in this study, they found that of the people interviewed, 24% were using methamphetamine as their main drug. And of those who were using meth as their main drug, almost a half reported an interest in reducing or stopping meth. And this was a non-treatment seeking population again. So what are the treatments we can offer? So really the standard of care, the best treatments are behavioral. It's not the pharmacologic. And we'll talk about some of the limitations of these, but they have actually very good evidence. And the one that I've started here is contingency management, because it's really has the most robust evidence for stimulant use disorder, both methamphetamine and cocaine. The idea of contingency management is that it's based on operant conditioning. The idea is to reinforce a behavior with prizes and cash. And so that behavior could be abstaining or cutting down, or it could be coming to appointments, getting the care that you need for your cardiomyopathy, et cetera. Often the prizes are given either through vouchers, sometimes with kind of increasing value for the more times that you've met that, whatever that threshold is, or for like a fishbowl method of a chance to earn a prize. And there can be incentives, as I mentioned, for a variety of things. Cognitive behavioral therapy also has very strong evidence, and it can be individual or it can be a group short-term session. And the idea of this is to examine the thought patterns that contribute to substance use and develop strategies to change them. And it's been found to have this sleeper effect where abstinence outcomes actually can improve over time as participants start applying the skills to their lives. Especially for cocaine, there's evidence for this community reinforcement approach. And the idea of this is complicated. I think it's a little hard to explain to people, and it's hard to access. But the idea is that it really provides comprehensive behavioral therapy, trying to adjust the aspects of someone's life that interfere with their health. And so the goal really is just to build a way of living without substances that's more rewarding than a life with substances. But it's extremely resource intensive. You can see that it can include relationship counseling, vocational guidance, therapy, etc. So I believe we've probably all experienced that there are real limitations of the behavioral treatments. I think primarily, that the access is very limited, But additionally, for people who have cognitive loss already, it might be hard to engage in those. There does tend to be high dropout, and with that, recurrent use. And then there can be regulatory barriers, and there is generally better evidence for cocaine than methamphetamine in these behavioral treatments. So what about medications? There are a lot of medications that have been studied for methamphetamine use disorder, and unfortunately with really little to show for it, again, no FDA approved medications. This was one of a number of reviews that have been done looking at just the long list of medications that have been studied. Okay. This is a guideline that's worth looking at if you're interested in learning more about methamphetamine use, not just management really, but background around methamphetamine and other stimulant use. And it was just published this last year, first in the form of a draft guideline, and then just a number of months ago, the final guideline came out. And I will refer to this just a little bit, but mostly I want to acknowledge that the medications I'm about to walk through, with the exception of psychostimulants, have been endorsed by this guideline for people to use without a lot of evidence for methamphetamine use disorder. So the first one that I'll look at is topiramate. I think topiramate gets, it's an old medication, it's been around a long time. It seems there's not any real incentive to try to make any money off topiramate, and so it's not FDA approved, for instance, for alcohol use disorder, but we know there's great evidence for it for alcohol use disorder, and I think it kind of flies under the radar also for methamphetamine use. This is one study of topiramate. So it was a randomized controlled trial of topiramate versus placebo, and it was a 12-week trial. Topiramate was up titrated to a target dose of 200, though only a small proportion achieved that dose, probably because of side effects. And the primary outcome was abstinence. And again, we talked about abstinence earlier, so very high threshold, but abstinence at weeks 6 through 12, so the second half of the study. And unfortunately, what they found was that abstinence did not differ. They did find that for those who had a negative urine prior to being randomized, meaning a urine that was negative for methamphetamine prior to randomization, abstinence was significantly greater in that topiramate group. And then secondary outcomes included urine methamphetamine levels and also observer-related severity of dependence. And so these kind of research scales looking at severity of dependence, and both of those were lower with topiramate. And there were no serious adverse events in the topiramate group. Okay, mirtazapine is another medication that has gotten, I think, a little more press and coverage lately. This trial that I describe here was essentially an effort to replicate a smaller trial that the same authors did with the same population previously. So they essentially replicated the results of their prior RCT. So in this trial, they took cisgender men and transgender women who had sex with men while using methamphetamine. They excluded those who had major depression, interestingly, since mirtazapine can be used for depression. And then they did a randomized controlled trial of mirtazapine at 30 milligrams versus placebo for 24 weeks, so doubling the length of the trial. The primary outcome in this trial was methamphetamine positive urines. No, it wasn't abstinence. And secondary outcomes included sexual risk behaviors and adverse events. And this was a very this was a very specific population, as you can see. There was not a lot of adherence support provided in this trial. Here are their main results at 24 weeks. So they had 120 people, 96% of them were cisgender men. It was a racially diverse group. So they had very low adherence in both groups, which is fairly common for trials of methamphetamine use, and especially for one without that adherence support. And ultimately, they found that there were 25% fewer methamphetamine positive urines in the group taking mirtazapine. They did find some changes in sexual risk behavior, depression, and sleepiness scores, and they didn't find any serious adverse effects from mirtazapine. And as far as those key outcomes of the methamphetamine positive urines, they found that there were effects at 12 weeks, at the end of the trial at 24 weeks. And then interestingly, they found that that effect was persistent out to 36 weeks, so 12 weeks beyond the end of the trial. You can also kind of see visually that the effect was not huge. This is another study that has gotten a fair amount of press, came out a few years ago, bupropion and naltrexone for meth use disorder. So both had some data as individual medications, and there was also a small pilot of these two medications, and then this was the follow-up to that. It was a 12-week randomized controlled trial using injectable extended-release naltrexone and bupropion, and both were used at very high doses. The researchers used a two-stage design in order to enhance their samples, so it's kind of a complex study design. And they were looking at people with methamphetamine use disorder who were actively using methamphetamine, who had a desire to quit or to reduce their use, and who were opioid free. Naltrexone is an opioid antagonist, so people who were using methamphetamine would not have been appropriate to include in the study. And they defined the primary outcome as a response to treatment. And what that was it meant having at least 3 of 4 urines negative for methamphetamine in the last 2 weeks of each stage. So each stage was 6 weeks, and in the last 2 weeks of each stage, there were 2 urines a week. And so you'd have ideally a total of 4 urines if people were presenting for all their visits, and the response to treatment was having 3 of 4 negative urines. So it wasn't abstinence, but it was still a pretty high bar. And this study, unlike the other, had a lot of adherence support, and you see that in these results. So they ended up enrolling 401 people. The average was 27 of the prior 30 days of methamphetamine use. So really frequent, almost daily methamphetamine use. They had greater than 75% adherence. And you can see the results on the right here. So divided by stage 1 and stage 2, and then kind of averaging those. And what they found is that in the treatment group, the naltrexone bupropion group, compared to the placebo group, there was a significant difference, an 11.1% difference in those who attained that response that they defined, again, as 3 of 4 negative urine samples. They found that adverse events were mild. So what about prescription stimulants? There's been a lot of interest in this idea of an agonist type treatment, similar to using an opioid for opioid treatment, for opioid use disorder treatment. So do stimulants work to treat methamphetamine use disorder? And there have been many trials, and there is some data. There was one meta-analysis listed here, which found that prescription stimulants are associated with increased abstinence and stimulants. However, the data was low quality and was really driven by the subgroup with cocaine use disorder. There have been some studies showing that in people with ADHD, so pre-existing ADHD who are using methamphetamine, psychostimulants can be effective in treating the ADHD. I'm going to come back to that guideline. So I mentioned that for the other few medications, so for topiramate, mirtazapine, and then the combination of bupropion and naltrexone, those medications are all mentioned in the guideline, said it's reasonable to prescribe essentially. And I'll show you kind of a summary on the next slide. But I do want to highlight that for the psychostimulants, one change from the draft guideline was that they really ended up saying only physician specialists who are board certified in addiction medicine or addiction psychiatry or have some similar level of experience should prescribe these medications because of the higher risk. And that was different from the draft guideline, which had suggested that they be used in certain situations. So to put that together, I'm thinking about medication. So again, topiramate, there is data for reducing methamphetamine use and for preventing recurrent use. We would want to try, in terms of just clinically how to use this, you'd want to titrate gradually due to side effects. And it's a reasonable consideration, especially in someone who has an alcohol use disorder, because it is effective in AUD. And of course, there are other comorbid medical illnesses where topiramate might be a pretty good option. What about mirtazapine? So there's fairly weak data for a small reduction in methamphetamine use. Both trials, the only 2 trials, were done by the same study group, and there are some methodological methodological limitations, which I didn't get into, but there are definitely, if you look really closely, there's enough to criticize there about the methodology. It was a very specific population, which limits the generalizability. But on the other hand, mirtazapine is generally felt to be a safe medication. We use it a lot in primary care. It has benefits for sleep and mood, and it might be a particularly good option in someone, for instance, with comorbid depression. So what about bupropion and naltrexone? There's really good quality, high quality data for reduced methamphetamine use for this combination. And the results that I showed from that study correlate with a number needed to treat of 9 for one patient to have a response, which is really, that's good. That's a really reasonable number needed to treat. The low attrition in their study and the very high adherence really limit generalizability. They had significant adherence support, and we know that the adherence in that study really was not characteristic for most trials of methamphetamine use. Again, these medications, though, are safe and they're generally well tolerated. They did use them at higher doses, and I don't think I mentioned that. So they dosed the naltrexone, the extended release naltrexone, every 3 weeks, whereas it's prescribed, or it's FDA approved for opioid use disorder and for alcohol use disorder every 4 weeks. So they used that at every 3 weeks, and then got the bupropion up to 450 milligrams, so a fairly high dose of both. Of course, bupropion and naltrexone is not going to be an option for the many people who are using opioids. All right, and then when it comes to psychostimulants like extended release methylphenidate, there is some data for increasing abstinence and decreasing stimulant use, but it is driven primarily by the subgroup of people using cocaine. It might be a little different risk benefit for people who have ADHD and are using meth. It remains an effective treatment for that group. But the guideline as it was finalized doesn't currently recommend using methylphenidate or other psychostimulants for meth use disorder alone for people without specialized training. Stigma is a major barrier to treatment, and we know that psychosocial barriers to treatment for methamphetamine use are many, but stigma is among the most prominent. So in this one study, 60% of people identified that as a barrier. There were other reasons people weren't necessarily seeking treatment, believing that it was unnecessary, or preferring to kind of deal with withdrawal alone without getting help. Privacy concerns was another concern. This SAMHSA figure here shows that when people get substance use treatment, it's often, it can be in a variety of settings, but we are really, if we're working in hospitals, emergency rooms, clinics, we're really not doing very well. We're not offering treatment enough. We're not welcoming people who use drugs effectively enough, and we're really providing a minority of the treatment that people do access in this country. And this was a comment from a qualitative study, and someone who uses meth commenting about how it feels, because some of the stigma around methamphetamine use. And this person said, you kind of feel sorry for the opiate addict, like they have pain, they're covering it up, they're not hurting anybody, they're just sitting there. Whereas meth, it's like, that's a psychotic person, that's a dangerous, insane person. I wanted to include a little bit on harm reduction for methamphetamine use, and I don't try to, this would, I think could very well be an entire talk and is an extremely important topic. So I just have a couple of slides on it, though. I know this is, I have crammed a lot of material into this talk. Here are a couple, I just want to acknowledge and emphasize really that the medications for methamphetamine use disorder are of limited effectiveness. The behavioral treatments are effective, very difficult to access, but everyone should have access to harm reduction. And there are a lot of ways that we can help people use drugs more safely, and just treating people, welcoming people, respecting their priorities, exploring what their goals are, supporting them, are all ways to help people who use methamphetamine as well as people who are using any drugs. This handout here is from the Harm Reduction Research and Treatment Center here at UW, and they have a lot of great handouts, and I like this one, ways to stay healthier when you use, ways to use more safely, ways to change how much you use if that's your goal. So it really provides a lot of options for people, but then also some very specific recommendations about how to keep yourself a little bit safer. And then also big picture, it's just really important to offer naloxone for everyone, whether someone is intentionally using opioids along with their methamphetamine or they're getting exposed to fentanyl as a contaminant, as an unintentional substance. Naloxone can be life-saving, and everyone should be offered more than one naloxone, ideally at least a few, or just ask them how much they need. We need to be diagnosing and treating opioid use disorder because even though fentanyl is a different area and even though use of methamphetamine can impact on retention in MOUD, MOUD is still life-saving, and we need to make sure we're expanding access as much as possible. We should always screen for viral infections, including not just HIV, but Hep C, Hep B, syphilis, etc. And then remember, PrEP is an option. A lot of people who use methamphetamine would qualify for that. So here are some closing thoughts. Methamphetamine is highly reinforcing and it has many acute and chronic consequences. It's important to understand why your patient uses methamphetamine and to address whatever symptoms and conditions you can. Behavioral approaches work, but access is limited. Consider offering medications. Think about the comorbidities and symptoms that people have as you are counseling people about those options. And then just remember that engaging people in discussions about their use and in discussions about treatment options is already doing something really important, and we don't do enough of that. We should all do more. Thank you. So that's the end of my talk, and I don't know.
Yeah, thank you so much, Jocelyn. This was really, really high yield, and really appreciate the great overview and some of the resources as well. As someone pointed out, that safer use resources really nice to have, and meeting people where they are. There was a question about predominance of use of medications for meth use disorder. Do you have a sense of that?
Yeah, let me see. I'm seeing a few questions in the chat, but I don't think I'm seeing that one. Let me see.
Oh, that one's in the Q&A.
Oh, okay. Sorry about that. Okay. Oh, that's a great question. I don't have a number, but I can say it's extremely low. I'd be very interested if anyone has come across any data around this. I have not, but it's very, very low. We know that, for a lot of, for something even like opioid use disorder and alcohol use disorder, maybe roughly 10% of people are getting treatment. For methamphetamine use disorder, it's got to be well under that. I'm sorry, I can't give you a number.
Thanks. I agree. It's probably very low. There's a question about why can't naltrexone bupropion be offered to people with opiate use disorder as well, given that we use naltrexone itself for treatment of opiate use disorder.
Yeah, thank you. That's really important. So it is as you point out, it's more complicated than what I said. I really consider buprenorphine and methadone, the two opioid agonists, to be really gold standard for treatment of for opioid use disorder. They have evidence that for many benefits, including reducing risk of death by like 50%, granted prior to fentanyl. But there is such compelling evidence that these are life-saving medications. And the same does not exist for naltrexone. It is FDA approved. They're also one of the studies that contributed to that, to the option of naltrexone, extended release naltrexone for opioid use disorder, was the XBOT study, and that was recently re-examined by other authors, and there were some errors with that study, and so both because of that and because of the current climate of fentanyl, I personally consider naltrexone to really be a lot lower on the list. It's worth offering to people through shared decision making, but there's never been data that it saves lives if you have OUD. There have now been some, good questions asked about one of the important studies. And I think really importantly, if for someone who is dependent on opioids and then takes naltrexone and loses that physiologic dependence and tolerance, they're now extremely susceptible to overdose if they miss that naltrexone, if they fall out of care. So I would consider it a lot lower option. But it is true that for someone with maybe very strong reasons for not wanting to be on any opioid at all, who still, goes through that shared decision making and chooses naltrexone and wants to be on naltrexone for opioid use disorder, that would be a great candidate to have to add bupropion to and to try to treat comorbid methamphetamine use disorder. So there would be some circumstances where I'd consider. The other where you might consider it is if someone is not intentionally using opioids, they're predominantly using methamphetamine, but that they're getting exposed to fentanyl, for instance, through the methamphetamine. And in that case, you could use it. But if they're really dependent and, addicted to the opioid, I would prefer methadone or buprenorphine. I hope that clarified my thinking rather than mudding it further.
Thank you. There's a number of questions in the chat as well. One on whether contingency management, if is being offered locally anywhere.
Yeah, I'm aware. What I'm aware of is it's being offered at the VA, which is great. And then I know that here at Harborview, our cardiology clinic had, or I think has still, a contingency management program. There's a lot of interest and there are some efforts around it. I'm not aware that there's anything sort of broader scale that's more generally accessible, but cardiologists here have become really interested because, of course, they see so many people with methamphetamine-induced and cocaine-induced cardiomyopathy.
Great. And then Tom has a question about, or is interested in the data regarding fentanyl and opioid contamination with meth, because he recently saw this report that the samples are actually based on medical examiner data, that there seems to be not that much fentanyl in the meth samples. Are you aware of any other additional data?
No, Tom, thanks for pointing that out. I was similarly very surprised by that. And Tom is looking at the reports from the ADAI, which is now, I think, publishing, so I think it was fairly recently they published these reports of I believe it was looking at people who report, based on what people report, what they think they're using, then testing and seeing what was found. And Tom is right, there was very surprisingly few of those with meth had fentanyl. I don't know, Tom, I feel like I have to look back at that. I'm very surprised by it, and I'm not aware of other local data. I do know that the comorbid intentional use is incredibly high. But for those people who are not intentionally using opioids, how likely is it that their meth is contaminated? I think it's safer to assume that it is, but are you aware of any other data or? Let's see, Tom said, what's interesting, this is also true in samples from, interesting. Yeah, no, thank you for that. I'll have to look into that more closely. I'm not aware. And someone also commented, it sounds like there was a presentation in Yakima on contingency management, and there's a pilot program at 9 sites across Washington, maybe by Washington State University. That's awesome to hear. That's great.
There's also a question about the CLIA waived fentanyl test strips and whether those might be available soon.
We have some access to fentanyl test strips. I guess I'm not sure. So is the question about actually being able to administer the fentanyl test strip rather than giving them out to people to use on
Yeah,
their own?
I think this person is talking about maybe a point of care type test rather than
Mm.
administering it
Mhm.
to the patient to use on their own for safety.
Mhm. Yeah, that is a good question, and I don't know. I'm sorry, I don't know the answer. That's a great question. I know that there's a lot, as I'm sure you all are so aware. I mean, it seems that there's just a lot of controversy around that idea, and a lot of the it seems like a lot of this testing is kind of on the DL because of fear of backlash politically. So I would be surprised if that happened soon, but it would be a nice tool to have, with the caveat that there's no this sort of proceed very cautiously at best, because we know that those fentanyl test strips are certainly not, can't give you an assurance that fentanyl isn't present, but.
Okay, it looks like we have one last question. Any evidence for bupropion alone or an SSRI like sertraline for meth use disorder?
Yeah, that's a great question. So there is some evidence for bupropion alone, and I think truly from a practical perspective, using bupropion alone or naltrexone alone is probably a more practical step to start out with, partly because of coverage. And there is some evidence. It's not the quality of evidence that you see in that New England Journal paper, but there is some evidence. As for SSRIs, they've been studied, and the evidence and studies have found that they don't work. So I would say no to the SSRIs, but yes to bupropion alone.
Thank you so much, Jocelyn, for this wonderful talk. Really high yield. And thanks everyone for all these great questions. Thank you for joining us on the first ACC for 2024, and we'll see you next month. Thank you so much.
Thank you.